Hello, everyone. Welcome to the webinar this evening. I'm Ted Newell with Eaglet Eye, and so I'm your host this evening. And we have a very interesting and fun webinar called OrthoK Angels. And to help me introduce the angels, if you'd move on to the next slide, we have Dr. Sheila Morrison, who earned her Doctor of Optometry and completed a master's degree in vision science with a focus on scleral lenses, along with a residency in cornea and contact lenses from Pacific University College of Optometry. She served on the faculty at the University of Houston College of Optometry, facilitating education and research in the contact lens and cornea service. And currently, Dr. Morrison practices at Mission Eye Care Center in Calgary, where she is the co-residency supervisor of the Mission Eye Care residency in cornea and contact lenses. And she's also an adjunct faculty at the um, NSU Oklahoma College of Optometry in Tahlequah. Our second angel is Dr. Alia Cappellani, and she received her Doctor of Optometry from the University of Waterloo and completed her cornea and contact lens residency at NSU Oklahoma College of Optometry. She is a fellow of the American Academy of Optometry and a Scleral Lens Society, as well as a diplomat of the American Board of Optometry. Dr. Cappellani currently practices and assists in resident supervision at Mission Eye Care Center of Dry Eye and Corneal Disease in Calgary, Canada. And finally, we have Dr. Andrea Lasby, who earned her optometry degree at the University of Waterloo and completed an ocular disease and specialty contact lens residency at, again, NSU at Oklahoma College of Optometry. She is a fellow of the American Academy of Optometry and of the Scleral Lens Education Society. She is the co-founder of the Canadian Contact Lens Academy and is a primary residency supervisor for Mission Eye Care's cornea and contact lens residency program. So we've got a few people that have a relationship with Tahlequah, which is great. It's a great school. Okay, so our agenda this evening is first, I'm going to go through just a few slides to review the eye surface profiler. We affectionately call it the ESP. Some people call it the Eaglet, um, and introduce it as a corneal scleral profilometer. And then we have another guest speaker tonight from WAVE, who is Shelby Walstad, and she's going to help us understand, give us an introduction to the WAVE system. And then finally, we're going to go into the clinical cases, which is what you're all really here for. You don't want to listen to me talk a whole lot. So we'll get as quickly to these clinical cases as we can and show you how you can use the WAVE software along with the ESP. So the eye surface profiler is a corneal scleral profilometer, and we're measuring height. And what we're trying to do with the ESP and with our software and in conjunction with the labs is we're trying to streamline the fitting process. So we take a scan, after we get that image, we want to analyze the data and help you as a clinician analyze that data. And then we want to work with the labs in terms of matching up with their lens fitting algorithms for lab of choice. And then we want to help you order the lens. And tonight we're really going to focus on how you do that with WAVE. So how does the technology work? Well, the technology is based on Fourier transformation profilometry. And so what we take a photo, we get a height profile, and what we have is two cameras, two cobalt blue cameras. They throw down a grid pattern on the cornea and on the sclera that has been infused with fluorescein, and that fluorescein gets excited. It sends us data back, which we turn into a height profile map. So it is a full corneal topographer. So we get all the metrics you typically need and expect from a topographer. We measure limbus to limbus, which is an advantage because we're getting the full cornea, not just 8 or 10 millimeters of the cornea. And we provide all kinds of bisphere elevation maps, corneal curvature maps, and so on, and a flow simulation. And then when you do your follow-up, we provide difference maps. So we have an actual and tangential curvature difference maps and a power profile to help you understand what's been achieved. But it's different because we have a lot of precision. It's height-based data. We don't extrapolate. We do pick up central islands, and we have a lot of precision, 2 microns at the center of the cornea. So I would add to that, we don't interpolate. So Fourier-based transformation technology does not interpolate data like Placido ring devices do and Scheimpflug devices do. So Aaron Wolf had a great poster on that where he showed the difference, and you will pick up some interesting things on an ESP. Coverage, again, limbus to limbus, so it helps with large lenses, high cylinder, the new freeform lenses where they want peripheral information. And then finally, we got a nice working distance, so the ease of use is terrific. We almost have 4 inches of working distance between the instrument and the patient, so it doesn't intimidate the children. We have a soft flash that people can easily tolerate, and it helps work with tight eyelids and also adds to the detail we get of the cornea. And finally, we have direct connect, and that is where we work with the lab of your choice. Tonight, we're talking about WAVE. And what this means is that once you've pulled up our images and you can look at them and you can um, see your clinical challenge, and that's part of the magic of this is whether it's the cornea or the cornea and the sclera, you can actually see your clinical challenge maybe for the first time that you've ever seen. And with WAVE, what we do is we export our data to the WAVE software, and it's very easy to do. It's you have your WAVE software on our computer along with the ESP software. Click a button, and the data is on its way. And I think that's probably a good place for me to turn this over to Shelby.
Thanks, Ted. All right. So thanks for joining. I am just going to give a quick intro to what we do at WAVE before you guys see some cases from the Angels. So the WAVE software enables practitioners to create a one-of-a-kind custom corneal GP, OrthoK, or scleral lens for patients based on their unique topography maps. We are completely topography based, so there's no need for fitting sets. And the designs are all driven from, again, the patient topography and will be completely custom to each of your patient's unique eyes. Just a quick overview of the process here. You're going to start with a good quality scan from a compatible device such as the ESP, and then you're going to import them into the WAVE software to create your designs. Once your designs are ordered, the lab is going to produce the lenses, and then they're shipped straight to your office where you can then just dispense them to your patients. We have developed a quick guide for each of our lens types and dependent on the topographer that you choose. So these are going to have our recommendations on how to design and then also some troubleshooting and modification suggestions. And when you start using WAVE, this is going to be put on your computer so you can easily access when it's needed. And then we also offer concierge lens design service. This is going to be a more hands-off approach to using WAVE. You basically send us your patient's topography maps, the prescriptions. We'll then design your lenses for you. And then when you see your patients back for follow-ups, you send over that eval info as well as the post-treatment maps, and then we will modify accordingly and send you new lenses. So again, that's just an alternative option if you'd like to use WAVE, but maybe you just want a hands-off approach to designing and modifying. And that is it for my quick little intro. I have our email up here, so please don't hesitate to reach out to us if you guys have any questions.
So Ted, I think we're good to go because I see that we have our angel slide on the very front. So this is where we're going to take over and start to go through some of our kind of clinical insights and cases and things that we've picked up along the way. And so just kind of to start off, if anyone out there was at Academy, Dr. Andrea Lasby and I were just there in Indiana, and Taylor Swift preceded us by just a few days. In fact, what you see is actually a photo of her. Well, not a photo, it's actually a large, like bigger than life Taylor on the side of the hotel of the conference. And so she really is a shaker. She is not a breaker, but we have some breakers in OrthoK that we want to share with you just a little bit. And some of the topics we want to go through that will either shake or break your OrthoK practices are kind of listed here. So we're going to go through data acquisition. We'll share a couple of cases that cover high versus low power OrthoK and how we use Eaglet to fit these lenses, and also some clinical tips for troubleshooting. So hopefully you can take some things back to your clinic, whether or not you're using ESP already, but just to bring into your practices if you're fitting OrthoK lenses. We have a really strong interest in our practice in safety. It's one of those things that, the minute that we start to see complications in contact lens patients, especially in children, it really has big implications for all of us and for our ability to prescribe these lenses in the long term. And so we wanted to take the opportunity to share with you within these cases and some of the things that we see that can really break our practices in terms of corneal staining and red eyes that are design related to dry eye, related to allergy, and also make sure that everything always comes back to solutions and handling and non-compliance. Now, Andrea, I wanted to kind of start off with this presentation and go through one of the most important things when we start off is quality data. With any topographer or any piece of equipment that we're using in the clinic, whether that be for contact lens fitting, managing glaucoma, looking for macular degeneration, if we don't have high quality baseline scans, we're never going to be able to follow disease processes. And when it comes to contact lens fitting, using poor quality baseline is really going to interfere with our ability to make really beautiful lenses. Can each of you give me a tip on successful data acquisition?
Yeah, I can start. So, I mean, one of the things that we saw early on when we brought in this topographer is if we don't use enough sodium fluorescein dye on the surface of the eye, then you're going to start to get some of those artifacts of dry spots. And you can see that in one of the pictures down at the bottom, where it kind of just breaks up and starts looking very irregular, sometimes not even, very smooth, where you see patches where just all of a sudden there's really no good data in a certain area. So that's really important to make sure that, your technicians, whether it's yourself that's capturing the data, or whether it's one of your technicians, make sure that they do have enough sodium fluorescein dye on the eye to really kind of like soak everything and make sure nothing's too dry.
I'll play this video again before I head over to Dr. Cappellani, just because I think Ted and I, and actually all of us, are used to the ESP, but for those that have not used it, the way that it works, just to recap what Ted was talking about, is it is a reflection-based system. And in this video, I'll just play it again. And what it is basically is that we're coating the eye in sodium fluorescein, and that's why Dr. Lasby really want to highlight that coating and using enough is really important, because as you can see in these pictures, the reflection quality is really dependent on a nice coating of fluorescein. Dr. C,
Yeah.
what you got for us?
Probably my big one to add is holding the lids wide enough. So right from those lid margins, you can play that video one more time. And you grab right from the lid margin, right below the lashes, and holding it wide open. So teaching the technicians it's okay to hold the eye that wide open to get the fullest ocular surface data that we can get is definitely beneficial.
I love this. And when it comes to training technicians, it's worth all the time that it costs us to really have a high quality training program, to have our technicians be able to identify what is good quality, what is poor quality data. Now, the next thing that we're going to go through is just kind of anyone remember Goldilocks and the Three Bears? So too cold, too hot, or just right. And when it comes to fitting OrthoK, there's a range that we typically reach for, and our best candidates for fitting OrthoK lenses, especially in the myopia clinic, really start around like a 1 to a 2 and go up to about a 6, and then astigmatism up to a -175. And there's no age limitation for OrthoK candidacy. In fact, in our clinic, we do fit patients of all ages, myopia control, kids, we fit adults with dry eye. And this is a little teaser of some of our cases. We're gonna hit high and low power with different ages and just kind of show you how we're able to handle that, because in the middle is truly just right. Too high or too low can be a little bit trickier. What would you rather fit, high or low? Andrea?
I would probably say high.
Okay, so we all want to fit the norm. We want to fit the range.
But if I had to choose one or the other, the reason why I like high is because for me it's great to get that amazing result that you get for patients, but just you have to watch for the drawback of fitting high and that you have very high sagittal depth lenses. And we tend to get a little bit more adherence with those ones where they're, either too flat right in the center and creating a bit of a staining pattern, which we'll go over in a little bit, or maybe the edges are a little bit too tight too. So it may be our climate. We're very dry here in Calgary, but we tend to I get more sticky lenses the higher we go, with more power. But I mean, who doesn't love to just be the hero to come in and fit a -8 eye?
I'll go the other way. I actually prefer doing the low powers. Think of someone that's not walking around uncorrected, a -1, and then, anything you do to them is gonna be beneficial. They're gonna be like, wow, my world is now so clear. But the tricky parts about that is that it's such a low power. We don't have maybe enough suction force. So the lens isn't giving us a nice centered treatment zone, or we go too much and go overboard. Now they're overcorrected. So a little tricky, but
The highs and the lows,
Preferred.
and they really are highs and lows. Yeah. Now, we like to always take the opportunity, and I've mentioned this before in other presentations, anytime that we have a platform to be able to get up and just remind to start off as we lead into some of these complications we see with OrthoK fitting with Dr. Cappellani. Anytime that there is a red, irritated, painful eye, anything with OrthoK that's out of the ordinary, we never, ever, ever want to ignore a red eye. In fact, a red eye is our friend. It's actually a sign or an opportunity for us to step in and correct something that could cause a bigger problem, because really that privilege that we have to prescribe could be threatened by unsafe use. We want to move into some of the things can kind of break our OrthoK fitting. So when it comes to corneal staining or conjunctivitis, red eye, some of the things we see in the clinic are design related. So I'm going to have Dr. Cappellani take over and start discussing some of the things that you'll see in these images.
yeah, there's a couple of signs on the cornea that we see that we can tell from the fitting. And so some occasional things that we can see is maybe a too tight lens. The lens is a little bit too tight on the eye. As you can see on the photo on the left there, that really, really thin edge lift there. And if we were to look at it, maybe we would have had to even press fluorescein under the lens there to even get the fluorescein under. That's a sign of a lens that's pretty tight on the eye. And so maybe in that case, loosening that edge there, flattening that edge, so that's not so close to the eye. Typically you can see that adherence staining there on the cornea, maybe in the first morning or something like that. The other way around, if the lens is maybe too flat, then we can actually get adherent staining right in the center there. And it's this kind of fine SBK right within the center, within that pupil there on the cornea. Other things, especially again, we live in a dry climate here in Calgary, and so we see a lot of dry eye, so much that we actually have a dry eye clinic. And so we're always making sure our patients go through that as well. And so just another, thing that goes along with contact lenses is dry eye. And so making sure we look at treating that either before fitting OrthoK would be ideal, optimizing the ocular surface, or when we're going throughout the fit, just the reminders kind of every time. A couple of things for dryness of the eyes, of course, preservative-free tears before and after insertion removal, and then throughout the day can also be used. Preservative-free stress there, of course, because we don't want preservatives sitting on the eye and with the contact lens while sleeping in the night. Also, treating MGD using warm compresses, lid massage, lid hygiene. We know that little mites and bacteria can live around the eyes, and so we don't want that adhering to the contact lens, which is sitting on our eye surface. So really important things to remember. And then one other important thing is a humidifier in a bedroom is actually pretty beneficial. If we have a little bit of leg ophthalmos or something, drying out the eyes, getting that humid environment.
I love that. We're seeing dry eye presenting in kids earlier and more frequently than ever before. I think we can all agree on that. We have doctors' meetings regularly at our practice. One of the things that we've talked about as a group is really trying to instigate almost like an ocular lid hygiene regimen for children, because when we're putting contact lenses on kids, whether they be soft or OrthoK, in particular when they're sleeping in them, anything we can do to increase safety and performance is definitely, overall a plus for everybody, patients and us as well as providers.
Other things to look out for, allergies. Allergies, of course, can swell the eyes, complicate the fit of an OrthoK. And so really watching out for those, treating those with your favorite allergy eye drop, kind of prescribed over the counter. what have you, but making sure that's under control is always important.
Yeah, I mean, the other thing to consider that looks like allergy but isn't allergy is also GPC, or even just contact lens related papillary conjunctivitis. It doesn't have to be giant papillae, but flip that upper eyelid every so often too, because we do see that a lot, and it can pull your lenses up. It can decenter them as well and create a little bit of just nondescript irritation and inflammation where the eye looks okay, but they're complaining that they don't feel normal. And so when you see that, just make sure to flip the lid, double check that there's nothing going under there, because that's caught me more than once before.
And then to your notion, I like what you said about that kind of subtle complaint where it just doesn't quite feel right. And one of the things that I see a lot with allergy, if it's not treated before we fit with OrthoK, is lenses will sometimes underperform just because they get a little sticky and they're just not in the right position 100% of the time during sleep.
Yeah, we've all been in those fits where you're like, what am I doing wrong?
Yeah, it looks
And
great. It's like, what's
it's not
the,
us.
yeah, it's-
Yeah, so some further investigation is always required. Lastly here, solution toxicity. You can see the cornea is kind of toxic over there. And we kind of tend to lean towards a hydrogen peroxide based cleaner just because it's preservative free, less sticky, things like that. There are other solutions out there, of course, but just keeping an eye out for maybe improper use of those solutions and preservatives on the eye. And so here's a little video here. Sheila, what do you think is going on in this video?
So this is a classic, this is lens adherence. And so what we do often at our practice, I think all three of us tend to have our one-day OrthoK fit coming in first thing in the morning as early as they come wearing a lens. And the reason that we do this is to catch things like this, because sometimes if a lens is adhered like this, I mean, you can see it from the topography, this is going to be a decentered treatment zone. But the adherence, sometimes we'll catch it just by having them come in wearing their lenses. Now, the question is to remove or not to remove. That's the true question. So when a lens is, this is an opportunity when I have a patient that does have a lens that's a little sticky in the morning on their one day, or if we, discuss or see something with staining on the eye and have to make a lens change, we always take the opportunity to really train people how to handle their lens. And it's not just one time that we have to do this, quite frankly. I often will find that patients that have been in OrthoK for some amount of time, you still have to circle back to recheck again what solutions you're using, how you're using them, and some little tips and tricks that I found on lenses, especially high power OrthoK, where they can be a little bit more sticky on average, depending on the fit, is in the morning, we train patients to leave the lenses on for, at least 5-10 minutes. You don't just wake up and rip your lens off right away. Number one, we want to get that lens moving on the tear film. You can do that by nudging the lid at the lens edge just so that they can feel it moving. In fact, we'll also tell patients, if you love the feeling of your lens when you wake up, it's probably not a good thing. You love it, that's probably stuck. If you can feel it, you're not going to like it as much. And that is a sign the lens is ready to remove. Now, polling you two, I don't actually know the answer to this. I just thought of it now. Are you guys doing any plungers for removal these days? Or is it lid removal for you? What would you say is best?
I'd say lid removal in case they're in a situation where they don't have that little plunger,
Okay.
something like that.
Yeah, we always are teaching lid removal at our clinic. However, I do have some parents who are doing it for quite young children, and they will have a plunger just in case. But again, we train them that is just for emergencies and not something, or you've just got a kid that's crying on the floor, rolling around. Go for it.
Whatever it
but
takes.
Yeah, but for the majority of our patients, it is always going to be manipulation with the fingers and the lids, and that's just because it will come off a lot easier. It's more gentle in the eyes than sticking it with a plunger and having to push that lens onto the corneal surface harder before you actually take it out.
All right, so clearly you're smart with OrthoK. So I'm gonna ask you another question. So if you had a number one tool for OrthoK, that we know there are multiple ways to get to the finish line. When we say this, that there are multiple ways, we're talking about so many different things. So there's different lens designs to choose from. We love WAVE, for example. There are different tools that we can use to get to the finish line and different ways of fitting. So what would you say, Dr. Lasby, is the number one tool needed for OrthoK?
For me now, it would be a topographer. And now if you pull me 10 years ago when I graduated from optometry school, I'd tell you, okay, the slit lamp, because we were fitting a lot of our lenses at that time from diagnostic kits. But now looking at clinic efficiency and looking at how accurate data can be from our topographers, we are fitting every single OrthoK lens that we have empirically. And so you cannot do that without a topographer. And it's really hard to troubleshoot what's going wrong as well without the topographer. You can't tell if the lens might be totally centered on the eye, but as they sleep, do you have a slightly smiley pattern where that lens is kind of moving up, or a frowny pattern where it's moving down, or even decentered laterally? And those things you just don't know unless you have a topographer. So really, I don't think that you can be a effective OrthoK practitioner without some form of a topographer.
And how do you choose which topographer?
So that's where kind of it gets kind of interesting. I know that those who signed up for this webinar, most of you are already fitting OrthoK, which I assume means most of you already have a topographer, which is great. If you don't have a topographer, what's nice about ESP, for example, is that it does everything. So a lot of the times people are not just OrthoK practitioners. They also fit scleral lenses, for example. And it's nice to have that one-stop shop. So if you are looking for a new topographer and you don't have one in your clinic, then looking at ESP is great because, again, it hits it on so many things where you can look at the cornea, at the limbus, at the sclera, and there's not a lot of topographers out there that can just do everything like that. If you already have a topographer and you're like us, where we love to grab every kind of new technology out there, then having an ESP is wonderful because maybe it can get rid of two things for one space. Space is the biggest limitation in our clinic. And so once you have, already you have a topographer and you're like, okay, I want a profilometer, but I can't, where am I going to put it? Honestly, hopefully after today's lecture, you'll understand that, you could probably get rid of that other topographer you have and just have your profilometer instead, because it will do the same thing. And you will still get your comparison map data, and in fact, maybe more accurate data looking at to 2 microns on the corneal surface or even 10 microns on the sclera. So I wanted to go over just some recent study. This was done earlier this year, and it was one of the first studies that I saw that actually looks at doing OrthoK with an ESP. And this looked at after 3 months of OrthoK, where how does that, orthokeratology, how does it impact the corneal scleral profile? Well, I think pretty obviously, it found out that it did impact the shape of the central and mid-peripheral corneal geometry. That should be a no-brainer. But it also showed that the peripheral cornea and surrounding sclera did not change. Now, we can assume that we knew that that would have happened, but we really didn't know for sure until a study like this one came out with a profilometer that proved it for sure. So this was really a kind of interesting data for us to see. But it goes back to when you are actually fitting, whether it's a corneal lens or whether it's orthokeratology. Studies from 20 years ago from Yves van der Warp and his team showed that it really is that mid-peripheral corneal data that optimizes your RGP design. So they found that 88% of remix in their study were attributed to having an incorrect mid-peripheral corneal shape found with topography. So if you're just looking at your autorefractor and getting your Ks off of that, you're probably doing more remakes, both with your corneal lenses, but also your orthokeratology than you need to be. And what's nice about an ESP is that you get that limbus to limbus data, so you can really see at the beginning, rather than putting a lens on it and finding out later, you can say, hey, I really need toric peripheral curves on this now. I can start with that from lens 1. I don't have to wait for lens 2 or 3 to figure that out. And that's why having an ESP profilometer is so effective when we're doing orthokeratology, and of course I love it for my scleral lenses, but it's effective for the corneal lenses as well.
We're going to jump into a couple cases. So we're going to start off with the high myopia case and just to paint the picture. We want to include a full patient perspective, kind of what is going on with this patient, not just that we're fitting an OrthoK lens. So 12-year-old female, referred to the Myopia Academy, which is a central part of our clinic that we house our kids for myopia control. In that clinic, we do all kinds of testing, including ocular surface topography, axial length measurements, cycloplegic refraction. In this case, this was a little one that the mother is hyperopic, father's a -4. My clinical take home is that if you see these parents plus and -4, and then the child is a -7, it's a testament to knowing a testament to the reality that just because there's a family history, or we can try to predict based off of genetics, you can't always, and it goes both ways. You can have highly myopic parents, less likely, of course, but sometimes they will not have a high prescription. And so that's why taking proper measurements of risk, including axial length, is important to us in our practice. And axial length, 26 millimeters, longer than 26, 26.3, 26.5. Cyclorefraction, which we do on all kids as a baseline, -7 with a fair amount of cell. Dr. Cappellani, what would your initial feeling be on this case if you were to just get this patient on your chair?
Yeah, looking at the high prescription there with some, moderate SIL as well. Lucky in Canada, I would probably jump to glasses. We can get that covered. Vision's gonna be excellent. We're gonna get some myopia control there. So something that we're lucky to have, and I'm sure worldwide you'll be using them soon as well.
I'm glad you brought that up because we have been really enjoying using spectacles in the myopia clinic, and that does not replace contacts and vice versa. We're going to show you these cases include both glasses and contact lenses for patients, and that's usually the best outcome. Any thoughts on atropine or axial length numbers? What does that axial length mean if it's 26 millimeters?
So we will compare our axial lengths to the Brian Holden Institute kind of axial length growth curves. So for this age at a 12-year-old female with axial length over 26, almost 26 and a half of that left eye there, that's over the 100th percentile. This patient is at high risk of having things like retinal detachments, myopic macular degeneration, glaucoma, cataracts as they get older. So it's very imperative for us that we try to slow this down as much as we can. So in a case like this, it's going to be a two-way discussion between myself and the family and the child to decide, okay, what are we going to do here? Whether it is glasses, but probably in this case, I'd be right away adding an atropine and saying we need a low dose atropine. 0.05% is probably where I would start for this patient as long as there's no side effects. But we would also discuss as well, potentially contact lenses, because lifestyle, 12 years old, almost a teenager, sometimes that matters. And sometimes they want that cosmetic, I guess fix and not having to wear glasses at school.
So here's what actually happened. So initially I tried to push single vision contact lenses, daily disposables with glasses on top to correct astigmatism. This family was dead set on OrthoK. I talked to them about the range that's usually the easiest versus the hardest for correcting, and that I can't guarantee that we'll be able to get all the treatment for a -7 with almost $2.5 of SIL. But we decided as a team we'd go for it, and we decided to fit with WAVE utilizing ESP. So this is corneal profilometry baseline scans. You can see that these have the ability to measure a complete cornea limbus to limbus with sagittal height data. And the most important stuff that we're interested in for OrthoK is that central portion of the cornea. And these are really beautiful scans to start off with. Now, the software is highly sophisticated. And so within the software, we're actually able to create lenses by using a lens fit. And essentially on the left-hand side, what you see is a list of different lens modalities. And I wanted to include this slide just to highlight not only just the OrthoK, because that's the feature of this presentation, but also soft lenses, hybrids, corneal GPs, scleral lenses. And within those first lens fits, what you do is select your manufacturer that you're wanting to work with, and utilizing data, it will actually either custom design a lens that's more freeform or OrthoK, or goes ahead and gives you a starting lens and parameters that you can play with. Each manufacturer has a slightly different flavor and a different personality, I would say. And the WAVE, for example, is a really great example of, I would say, highly sophisticated, user-friendly software that can be used with a variety of different lens modalities. And it's been a lot of fun for us at our practice working with every single one of them with the WAVE folks. They're fantastic. Now, here's our initial lens design within the WAVE software. So this is where things get fun. And as Shelby mentioned, it can be really concierge style, where you just have the lab create the lens for you, and just like magic, you're the hero, put it on the patient, everything's fine. For those of us, especially a lot of WAVE users are very, really like the technical side of designing lenses, especially OrthoK. And I hope there's a few of you out there that are really hardcore WAVE fitters, because the software used to be very hard to use, and it's not anymore. Now, you can see that in the design, the software is very easy to see, and it's for us been very easy to modify. In fact, we have our resident now who is, whenever they're fitting a WAVE lens for the first time, can actually go in and design lenses on their own, of course, with help from Shelby and the team. But it's very user friendly. And so this is kind of how the lenses look. Now, the cool thing about what we've learned using different topographers and then using ESP, the software is highly capable of generating difference display maps, tangential curvature maps, and also the axial curvature maps. So we have day one, you'll notice, is very different. And I just want to go back. Tangential curvature position maps, axial power maps. This would be your power change. And on day one, it is not uncommon for maps of all topographers, including Eaglet, to go ahead and look a little bit. You might notice on the right, an incomplete treatment zone, not uncommon on the first day. And by day 5, a lot better. So here's what we see with our lenses on the right and left eye. Here's a power map. And then this is the fun one, the difference display map. So we have a tangential difference display and a power difference display. And what these are is really the essence and probably the most important display feature in any topographer that takes our baseline cornea, compare it to our post-treated, and looking at the difference between the two. And that is how we know how much treatment we're getting. Is our treatment centered, and is it effective or is it not? Now, here is something that came up in our patient. So I will just skip ahead. I'll explain kind of where we landed with this patient using our WAVE ESP-driven lenses, and just pause in the middle of this case because on one of our follow-ups towards the end, here's a complication. So I'm getting this kind of scratchiness looking on the cornea. Dr. Lasby, how would you know if this is adhesion from a lens or if this is a handling abrasion?
So this one's interesting because if you look at how the actual fluorescein looks there, a typical like sticky lens, I'd look to see more of that punctate keratitis staining. But this one, you can see almost more like vertical tracking. Now this is definitely a dry eye, but you know, is there an issue with handling? So at first I would definitely say, okay, I need to review handling with you. I want you to show me, how do you take it out? How do you put it in? And make sure that they're doing both with preservative-free eye drops, artificial tears. So whether they're putting it in, doing a drop just to cushion it as they put it in, or making sure they have those preservative-free eye drops before they take it out, and ensure that that lens isn't getting too sticky and it's not really, you know, they're scratching it on the way out or blinking really hard as they kind of go to get it out. And then the other thing to look at with this particular staining is there just something getting trapped under the lens? And then
Yeah,
as they're
that's a good one.
blinking, it's just kind of like tracking across the cornea.
Very similar to what we'd see in a cornea GP. And actually, I'm glad you I kind of forgot about that with this case. That is it's not uncommon that we see that too. So it's all these kind of pieces of the puzzle. Now, her results, so I wanted to have just a brief results discussion. There were lens modifications needed to finalize this lens. Often we do see that even regardless of the topographer, you know, and beautiful data from the start, with high power OrthoK, it's not uncommon to have to make a little adjustment. I find, you know, we're compressing a lot and getting a lot of change. And sometimes at that end point of that first lens, we can squeeze a little more out of it. So in this case, we ended up getting the patient to the first lens, you know, a certain point, and had to adjust the fit for a little bit more treatment. And also her edges were a little tight with the high power, ended up flattening. Now, our final endpoint for this patient ended up being a 20/25, which is very good vision. And the overall refraction at the end of the day was a -50. And so in these cases, with the high power OrthoK, one option, because they love their OrthoK, they're getting myopia control from it, freedom from glasses or contacts for most of the day. But for kids, especially if they're driving, or do you notice that at the end of the day, it's a little bit not as clear as the beginning of the day? I'll often do an end of day spectacle or end of day sports contact lens in these cases that we're just needing a little bit more, but we're at the limit of what the OrthoK can do. Andrea or Dr. Lasby had already mentioned the atropine. We went with 0.05% compounded. And then always single vision spectacles for backup for every single patient. Cannot stress that enough. You know, it is especially difficult in OrthoK, high power. If patients have an issue with a lens or an eye infection, but do not have backup glasses, it's a huge, big thing. Unlike a low power where it's like, you know, I could get by for a day or two with a -1 or 2 even. But with a -7, if they don't have backup glasses and suddenly they can't wear their contacts when they're used to it, that's a big problem. Our regular follow-up for these patients is every 3 to 6 months.
Yeah, and one more thing on the glasses is that especially for higher powers, anything maybe over -4, you might want to actually consider giving them like a -4. You know, when they go to a sleepover, they forget wearing their lenses one night, and then they're not all the way -7. They're just maybe not as good as they used to be. So having a pair like in between can sometimes be really helpful, especially for these like adolescent, early teenagers too, where sometimes adherence to the treatment isn't always
They take a night off.
easy. Yeah, or you know, they you know, only work 5 hours instead of a full 8 hours
Totally.
of sleep. So having something that's maybe just not quite their full power, but something a little bit less to get them by, can also be really beneficial.
Nice. No, we were all kind of, I would say, all of us are fairly nerdy. So was the folks at Eaglet, so are the folks at WAVE. We all love the science side. And so in discussions with Elena earlier this week, Here's a new literature alert, that a paper that we found. And the reality is that there's really not a whole lot out on that's been, lots and lots of case reports and studies. And that's why it's just so exciting for us to be out here presenting and sharing cases, because profilometry driven OrthoK fitting is relatively novel compared to other topographies. And this was a new piece of literature that really was looking at it wasn't looking at fitting lenses at all, but it was something that we came across that's related to myopia control. So just threw it in this paper. It was a study done to determine how corneal scleral geometry changes with axial length. And in this case, utilizing ESP measurements, what they found in this study was that larger globes show reduced temporal nasal scleral asymmetry. And in fact, this could be a site of interest when looking at what are risk factors for myopia progression. So that's our little aside on that. Now, our second and last case before we move on to having time for questions is a total opposite side. This is Alia's dream patient. 24-year-old. He's actually our staff member, so we can talk and say whatever we want about him. He gave us full permission. In fact, I was going to show a picture of him. If I had one, I would put it on there. He's great. He just wanted freedom from glasses and contact lenses. Ocular history, part of what drove him to ask for OrthoK. He was interested in it, but also had dry eye symptoms with daily contact lenses. So he was in a DT1, which is a pretty good lens for dry eye on average, one of the premier lenses, -1 OU. His other ocular history, just not completely unremarkable. He had CD asymmetry, so a little bit of a risk for glaucoma, and also had some retina hole repairs, which are kind of fun pictures to show off. So we'll show you those as well, just to keep a full rounded case, because the reality is, as much as we love our front of the eye, we are dealing with whole humans in the clinic. This is his fundus photos on your left, which is his right eye. You can see that the cup to disc ratio is a little bit larger than his left eye, which is imaged on your right-hand side. Eye pressure on average kind of fluctuates, being fairly symmetrical, and his nerve fiber is completely normal. So in this case, just kind of a physiologic thing that we'd be watching more as he ages. Patient had some retina holes at one point. In fact, as a worker at our clinic, or as one of our team members, was one of the first times that he had come across some of this imaging and had, some symptoms, flashes, floaters. On the right eye, on the top left, is a fairly large tear with fluid under it that he had to get repaired under our care, which was kind of fun. And then on the right-hand side, on your right, his left eye was an old hole that they're just kind of watching. So those are just things that are just kind of for fun, just to give a full case presentation of this patient. Dry eye, anytime a patient comes into our clinic, especially adults, for contact lenses and ask for something different than their contacts, we also, we consider OrthoK, but we also consider what can we do to manage the ocular surface, as Dr. Cappellani was talking about earlier. In this case, at the end of the day, this patient, our staff member, had a little bit of a lower tear breakup time. He had MGD, not enough oil production. And generally, I think because of his ergonomic and the work that he did working on screens a lot, just led to some of his dry eye. So he's a great candidate for adult OrthoK, aside from his prescription. So what did we do? May as well just really try to push the software, is what we thought. We'd see if we could try fitting this low power OrthoK patient with lenses again, so WAVE lenses. Now, this is another sort of example of our software. So within the software, this goes a little further to kind of highlight and show what we can do. We can spin around the dial, around the clock, to show where the fluorescein pattern or what it looks like at any given point of the lens. The software can be modified to adjust for, iris, all the different parameters that we would consider when fitting any lens. And then, of course, the left eye. Now, I have to point out, this one was kind of a case that we want to keep this failure in, just to share a clinical pearl, in that sometimes, there can be things that you have to watch out for in software. Now, in this case, the reason we didn't dispense the first lens was that it was a large diameter lens that was a little bit too big for this patient. So even with really good quality data, so we think sometimes dry eye can affect our scans. And when we intentionally, in this case, pull just from the software without eyeballing it ourselves, sometimes we'll get the odd thing that doesn't exactly translate. And so the lesson here that we want to share was that our patient, needs a little bit smaller diameter lens. 11.7 is just a little bit too big. And so again, just redid them a little bit smaller. Same story, you can modify and have some fun with it. And our first lenses were dispensed with just, nothing really different that we did aside from a smaller diameter lens. Mm-hmm. Here's our results of the first lens. So the first dispense lens. And what we found with this patient, when fitting low power OrthoK, I would say, is not necessarily, uncommon to sometimes overcorrect. And that's often because we have to apply a higher Jessen factor. Sometimes the lens is almost, when we dispense a low power OrthoK lens, when we're dispensing, they almost look like they're fitting a little flat. Because as Andrea mentioned, that reverse curve is really not very high. It's almost essentially barely any different than a regular corneal GP with a small reverse curve, because the power we need to change is not super, super high. On the bottom left, you can see his post-treatment refraction was actually plus. And so this is something that we do see. He had really good vision with the lenses on, but with treatment, the lenses worked a little too well. And that's a clinical pearl when this happens in the clinic. I get it with kids every so often as well, where I'll be like, your lenses are working too good. And so we need to cut it back a little bit. Now, I wanted to take this chance to just talk about the Jessen factor, because this was the primary thing that we changed in our WAVE lenses. We tend to choose a Jessen that's just a little bit higher, and that's often very effective with high power OrthoK. The Jessen or compression factor refers to kind of an additional refractive buffer that we add to target correction to ensure that we have acceptable unaided vision. And in this case with our patient, the solution to this overcorrection was just to decrease the Jessen factor. So we did that, had our final lenses, and results were really quite good. So 20/20 vision, very happy, can read everything, no accommodative issues, single vision glasses again for backup, and follow up every 6 months. Now, in summary, we are on perfect schedule. I'm very proud of us. It's with 3, you never know, we could really go too short or too long, but we're right exactly where we want to be with a few final clinical pearls. Digital design really does get us to great starting lenses quickly. And that is something that, the world buys into. We know this is true. It does not replace responsible, skilled fitting. What that means is management of complications, taking time to get to know the lens design, and not just click and shoot, which you can kind of do parts of that. In fact, when I get busy in the clinic, absolutely, I lean on software and lean on consultants to help me to kind of get things done quickly. But at the end of the day, as providers and when we're prescribing lenses, understanding the lens design, understanding how to manage complications and how to address some subtle things in the fit are certainly imperative to be successful. Topography, profilometry, essential for OrthoK, safety and compliance. I think we've tried to make that a really kind of important thing that everybody absorbs and brings back to their practice. Many tools will get us to the finish line, and the ESP is very compatible with WAVE OrthoK, among other lens designs. So with that, we would like to just give the opportunity in the last 2 minutes if there are any questions, or open to Ted to guide any discussions that you may like to get into, Ted.
Sure. Thank you very much. That was a terrific presentation, and 2 very interesting cases. So thank you to the Angels for putting that together for us. And also thank you, Shelby, for your assistance on the WAVE side. But we do have some time here for some questions and answers. I know Shelby has been busy answering some people in the chat about the availability of WAVE in Europe and in Latin America.
Ted, could
So
you go
she's
through, could you highlight some of the main, like if there's any questions that maybe the person that asked it is not the only one that would ask that question?
Well, we've had, gosh, several people ask about, like Dr. Kies, I don't know if I'm pronouncing that correctly, asked if the software or the WAVE software was validated in Europe, and Shelby's answer was yes, it is.
Very cool.
And then we had so there's a question I'm going to get to in a second. Then is it possible? Is this WAVE software possible to use in Latin America? And it is. And so she was answering that question. That was Dr. Villanueva. And another question we had from Dr. Jean Groot was, can I fit OrthoK for hyperopia with WAVE? And Shelby answered yes. I don't know if maybe you want to talk about that a little bit more, about fitting OrthoK with hyperopia,
Sure.
Sheila?
Yeah. Oh, go ahead. Sorry.
Yeah, Shelby, feel free to hop in. I'll add
Go ahead.
anything if there's anything that I can add after you answer
Oh,
that.
sure. Yeah, I was just going to say that we can fit a hyperopic OrthoK with WAVE. It's a little bit trickier because it is off-label, of course. But you have the capability to fit in our software, and we're kind of starting to create a little bit more educational, we're doing webinars, we're doing quick guides and stuff for this, just to explain it a little bit better, because it can be a little bit tricky, as you know.
Okay. And then we have another question from Dr. Garcia. What topographers are compatible with WAVE?
Sure. Yeah, so the ESP, of course, Pentacam, the Keratograph, Medmont. I feel like I'm missing some, but those are the main ones. We're working on getting compatible with NIDEC as well. So those are the main few.
So if somebody had a different brand than the ones you just mentioned, is there a way for them to still work with you to send the data in to one of the consultants to create a lens?
Yeah, so you can create a K-sim lens. So essentially, you're just going to put in the patient's Ks and the eccentricity from whatever topographer that you do have. And then you can use the software to still design and modify your lenses. It's just not going to be that like custom freeform lens that kind of, I think, sets us apart from other brands.
Okay, and then Dr. Elbada is asking, is it available in the Middle East?
I don't believe so. I think we'd have to confirm exactly where. Yeah.
Yeah, that was sort of a general question. If that's, I'm assuming that meant WAVE, but if it's a ESP, yes, we can ship to the Middle East. Different countries have different device regulations, so it just sort of depends. But we've been successful so far. Um, and then somebody asks, whom should I reach out to if I am practicing in Malaysia? And go ahead. Well, it'd be Brighton Optics for the ESP. So Brighton Optics out of Taiwan, and we can provide that contact information if you want afterwards. What about for you, Shelby, for Malaysia?
Yep, I think they said for ESP, but I can put in the email for them to reach out and they can help out with all of that at the info@wavecontactlenses.com email.
Okay. Um, okay, so I'm trying to think, are there any other questions? If we missed something, Sheila, that you and your crew would like to um, expand on before we depart?
No, I just can't say enough of gratitude. And I'm very impressed at the global presence of listeners. It's really wonderful to connect with people all over the world. And if there are any further questions, feel free to reach out to any of the folks at WAVE or Eaglet to get a hold of either of us or any of us. And just, yeah, no, we've really enjoyed the journey. So there's nothing else that, unless there's further questions.
There is one question that is interesting.
Sure.
Dr. Garcia asks, up to what sphere and sill can we customize a lens?
On label or off label?
Give us both.
So, I mean, if you look at, there are some key opinion leaders and very experienced members of the WAVE family that I've seen them present on parameters that are up to, 12s and 13s and things like that. That's definitely off label. So that would be a conversation to have probably with WAVE about what they're willing to do or what they can do. I probably would say in our clinic, like the limit that I would push is about like an 8 with a couple, maybe a 1 to 2 diopters of cylinder would be my personal where I will push it to. Other than that, I always set an expectation that we can get most of the correction, but there's likely going to be some residual left that will have to be corrected with soft lenses or spectacles.
Yeah, generally for me, WAVE is what I reach for when I know this is going to be really challenging. And so when I do have something over like a -8 or I have something with sill over -1.5, I'll generally reach for WAVE. And I've probably gone up to sill about a 3.5 before. So it can be done. It's not done all the time. But WAVE is an excellent lab to look to if you are looking like you've got a really motivated patient and you have a really complicated eye.
Okay. We do have another question, but I also want to point out that in the chat, Elena, who's in the background helping us pull off this webinar tonight, she copied this slide that you see right now with the contact information for both WAVE and for Eaglet Eye. She copied that into the chat. So if some of you need to pull that up and need to contact us later. And then another question from Dr. Obata is, does it work with early keratoconus, OrthoK?
No. But personally, yeah, so I mean, I'm sure it would work, but it's keratoconus would be a contraindication for OrthoK.
Okay. Okay. Okay, that looks like all the questions we have at the moment. And like Sheila said just a minute ago, that if you've got more, you can reach out and we'll make sure that the questions get answered. And again, I'd like to thank Sheila, Alia, Andrea, Shelby, and Elena for putting together the slides and a terrific program. And we wish everybody a good night and good rest. And we'll see you someplace else, maybe on a trade show or a congress or wherever that might be. But again, thank you very much.
Thank you.